thank Parker Severos for inviting me to speak in the New York Chiropractic Council. I'm Dr. Cuccia. I've been a chiropractor for over 30 years. And I want to discuss today some of the advances in machine design for applying distractor forces to the spine, or traction to the spine. I want to tell you a little about how I got started in this, because we have plenty of time. We have a nice audience, so we can take a nice little step back and discuss what happened to me about 30 years ago. I had a patient who was a nurse. It was about 3 years in practice. Go back to 1983. She came in with severe low back pain and radiating leg pain. I was a pierced steel wagon practitioner, of a cervical practitioner. I studied flexion distraction. I did every imaginable therapy under the sun for this particular person that was bent at a 30-degree angle, leg pain down the opposite side, and included flexion distraction protocols. And nothing was helping this poor woman with disc problems. She was in an earlier model of a Trident table, linear traction table, had no clinical effect on her whatsoever. She was bent like this. So I had what they call a desperate moment and an epiphany. I said, you know, I'm going to do something that's a little different than what I was trained to do, which is put a patient with low back pain in flexion. So I'm going to take this patient, who's about 240-pound female woman, and I'm going to put her over my back, and I'm going to combine the extension with dynamic lifting, and I'm going to see what it does, because I don't want to fail. I hate failing a patient. I'm sure all of you are the same way. As chiropractors, we're great healers, and we don't want to lose any one patient to surgery or other interventions if it's not necessary. We want to help them restore their health. So I picked her up, and after 3 months of chiropractic care, standard chiropractic care, which is all those techniques I used, she was standing straight. The pain was out of her leg, and the antalgia was gone. And that began me on a quest, which some might say has taken me now into 13 countries. We just opened up China. We're opening up Ecuador and some of the major industrialized countries and major rehab centers. And I teach physical therapists, chiropractors, neurosurgeons to use it. Some neurosurgeons put on their surgical gowns and they start working on Extentrac. We have some pictures we're going to show you that. I'm going to tell you some stories because I'm so glad that you're the crowd that I have, because I feel very comfortable. Because I'm not really a seasoned public speaker. I'm somebody that actually was many, many times on my own. Now I have a corporation that builds these units. And the purpose of the talk is not to sell my unit. It's to describe whatever unit you have, how to make it work better. This is not a marketing discussion. This is a technique discussion. So with that, for 2 years I lifted patients over my back. I go into a house, a lady at 350 pounds, I get her out of bed. She couldn't move, pain down her leg, and I'm trying to get her up. I remember one day, no air conditioning upstairs in the house. I picked her up and I stretched her. I almost killed myself. But she got better. For 2 years I put patients on my back. Then I got this brainstorm, and I told my wife, who's been tremendously supportive of this whole effort. I showed her some straws and some little Play-Doh, and I showed the relationship of all these movements you can put a patient in and combine traction with. I had pipes dropped off at the house, and for fence, I borrowed one of my patients' electrician's pipe bender. And of course, when you're bending a pipe to make the curves that you needed to extend the patient, because the Extentrac has a 30-degree curve in it. And you need that. Years later, I hired engineers to design better than I thought they could design, and they made straight bars. And how can you bend the body through straight bars? So anyway, this electrical device to bend pipes, a conduit, like on the wall or whatever. As I was bending the pipe kind of slipped out, knocked me out, and I was hospitalized. Plus my eventually building this machine, in years past, I burned my garage down because I had to weld. I had to learn welding. I remember taking bare metal and cleaning it, repeatedly cleaning it, because you get it from the metal shops. And they used to think I was crazy in metal shops. I used to walk around metal shops. And he said, what do you need? I said, I'm not sure what I need, because I'm not a classical engineer. Even though patients look at the machine today and say, gee, that's a remarkable machine. How did you make that? I kind of just innate. I guess that's where innate is flowing in all of us. And that's why it's M3D, because you're going to use your innate observation of the patient to create what position the patient needs to get him well faster or more assuredly than just linear pulling tables. So I built the first table. We're 5 generations later. And from having difficulty projecting a unit into Brooklyn, New York, my legs working with fellow clinicians, because there's an attitude of wanting to help the patient. It's not so much economic in these countries. We do a lot of work overseas. It's how we can help the patient. And I've noticed that they want to get the best equipment. What's the best thing we can get to pick, and what's the best technique? So it's fun working with them. It's a very, very honest relationship we have with them. And I made quite great friends.